So I'm Dr. Amar Burhan. I'm a geriatric psychiatrist and endowed research chair for mental health at Ontario Shores.
Let's talk about Alzheimer's, dementia, cognitive decline.
Right.
What are each of them?
Right. Yeah, so I think probably the best order of thinking about these is cognitive decline in general, because that's a more like general term to say a person probably will have less cognitive capacity due to many reasons, aging being one of them, but it's not usually a cause for pathological cognitive decline. So a person will change in cognition as we get older, but then it wouldn't be considered an illness unless it crosses a certain threshold. So then you start thinking, well, is it crossing enough threshold to be noticeable to other people? And is it something that we can measure? So then we call it mild cognitive impairment. So a person will say, okay, well, my memory is not as good as it used to be as I got older, but I'm still doing okay compared to other people. Or they may say, oh, I'm getting a little bit forgetful, but it looks like still not being detectable by any measure. But the minute it becomes detectable, meaning that I can measure it and I see, okay, well, your memory is not as good as it used to be. It's below, one standard deviation below the mean, but you're still functioning very well, then we call that mild cognitive impairment. And then you go to a dementia where now the problem with memory and other aspects of thinking, such as figuring things out, expressing yourself, now started affecting your independence. So then we call it dementia now. A person is unable to survive completely on their own because now their memory function or executive function is now coming in the way of their independence. So we call it dementia. So that's the general term. But then as you start thinking, okay, what causes it? So Alzheimer's is a cause of dementia. It's one of the most common causes of dementia in old age, above the age of 65. And it's a neurodegenerative illness that results in a progressive loss of nerve cells and connections. So dementia, again, is really a syndrome that could, a person could develop a dementia after a major stroke or after a head injury. But really, when we talk about Alzheimer's disease, it's the neurodegenerative illness that progressively get the person to lose their cognitive skills. And then when they cross that threshold to being affected in terms of their inability to stay independent, then we call it a dementia due to Alzheimer's disease.
What's happening with Alzheimer's? What is Alzheimer's?
Yeah, so Alzheimer's disease is now understood relatively better than previously. It has been over 100 years since it was first described. It is definitely a progressive loss of brain cells and connections, and it's usually caused by a pathological process, meaning an accumulation of abnormal protein in the brain. Now, the question would be, is it something that is inevitable with aging? Now we know that it's not. It's actually an illness. So basically, not everybody will develop Alzheimer's disease as they get older, but there will be increase in the number of people who develop it as we get older. So meaning that by age 85, there'll be about 1 out of 3 people that will have it, right? So it is significant, but it's not everybody. So we now know that it's driven by changes in brain proteins that result in toxicity, that result in neuronal and connection loss. And then, of course, it manifests itself by the inability of the person to remember information, or the inability of them to find their way around, or finding words and so on. So we now know the 2 proteins that are a hallmark of this illness. One is called amyloid, and one called tau, or TAU. And we, in fact, got all the way to find therapeutics for that, and we can talk about that a little bit more. So just to summarize then Alzheimer's disease is an illness that causes dementia. And it's a very common cause of dementia in old age, and it's due to accumulation of an abnormal protein and progressive loss of brain cells and connections.
Plaques and tangles, what are those?
Right. So I mentioned in my previous answer that amyloid and tau are 2 proteins that are abnormal in Alzheimer's disease. So the plaques are basically really, it looks like a literally like a cigarette butt when you kind of extinguish a cigarette. It's a scar in the brain, and that's actually usually made of amyloid. It's like fibers of amyloid that get accumulated and stick to the tissue, and they're not healthy. They're actually outside the neurons, but they're not healthy because they create inflammation and create a progressive loss of neuronal health. So the plaques are amyloid. They're that protein that I mentioned earlier that accumulates, but accumulate in a wrong way, shape and becomes sticky and create a scar in the brain. The tangles, on the other hand, are basically the other protein called tau, T-A-U, which is inside the cells. It's instead of being streamlined and linear, it starts getting twisted and clumped, and then it becomes basically abnormal, and the cell will die. It cannot survive because those pathways inside the cells that is made of that protein tau needed to stay linear to be able to transmit like chemicals inside the cells. When it gets clumped, there's no longer a good pathway for those proteins to move around to give the physiological function we need.
So what are you looking at right now, today? Mm-hmm. What are you looking at?
In terms of like what the Alzheimer's?
In terms of discovery, in terms of right. Treatment.
Mm-hmm. Right. I mean, one really major advance that happened very, very recently in Canada was that in November of last year, 2025, we got the very first approved disease-modifying therapy, meaning a treatment that could go after the pathology in Alzheimer's disease. Prior to that, we were looking at improving the quality of life and symptoms. We had some medication to help just boost some of the chemistry to help the person think better longer. But really, the first time in the history of this illness, it has been about 2 years in other places like the United States and Europe and Asia and Japan. But in Canada, in November, finally, Health Canada has approved the very first drug that will go to the brain of the living individual with Alzheimer's disease, but in the very early stage of the Alzheimer's disease, and take away that amyloid from the plaques that we talked about and clear it out of the system. And we can see that because we can image the brain before and after, and there has been a clear demonstration of the protein, that amyloid protein, abnormal amyloid protein being removed. Now, if you remove the amyloid without getting any benefit, it wouldn't be as useful of an exercise. But in the clinical trials that have been done, we did see that the illness is now delayed by, on average, something like 10 months for, now that's average. So some people had longer delays and some people shorter delays. So that led to the approval by the Federal Drug Administration in the United States. And then since then, we have been trying to get it approved in Canada, and we published a paper on what is the meaning of this for Canada and in the health system that we have. And today, we have the drug already. We have a drug with a drug identification number, and it's actually being delivered. In fact, it has been delivered already clinically in Canada. So it has been delivered previously as a research, but now there are some people who have been infused already as a clinical patients with this drug. What that going to translate to is that the possibility of us continue to improve those treatments to arrest that illness instead of actually having to just be at the mercy of it progressing, and we keep trying our best to help the person and their families. So that's one major advance. The other major advance, I would say, that people are becoming much more aware of the utility and the usefulness and the availability of prevention. So there are about close to 50% likelihood of actually preventing Alzheimer's disease by addressing modifiable factors, including hearing impairment, depression, preventing head injury, alcohol use kind of modestly instead of excessively, smoking, and so on. So the two fields are really now very active. The prevention field, which really target people who are still not ill, but they may be at risk by getting older or by having family history. And there's the now specific disease-modifying therapy. So, and the other aspect that are more involved in kind of improving quality of life is really symptomatic treatment. So we're still looking for more and more tools to help people who are dealing with maybe abnormal behavior due to these difficulties, for example, anxiety, depression, agitation, psychosis, all these things that could happen in this illness. So we're very active in that as well. So there's a lot happening in the field.
I understand they're also looking at a connection between your gut and Alzheimer's as well. So
Yeah.
what's that?
Yeah, I mean, there's a whole line of work looking at neuroinflammation, but also neurotoxicity from things such as the microbiome, we call it, which is in our guts. We have really like a whole population of bacteria that is in the billions and trillions probably in terms of numbers. Usually we have normal flora that are live with us and kind of we benefit from each other in a way, but there's more and more knowledge now about how our diet and our lifestyle can change the population of bacteria in our gut, and then how much of that could create inflammation in the body, could release some toxicity to the brain. Some of the mechanism, inflammation is one, that's a big one, but also through chemicals that are normally excreted by these bacteria, but may look like some of the chemicals in the brain and may create, two-way pathway. So I'm not aware today of any particular treatments that driven, but definitely a lot of research on that area of understanding the microbiome and how healthy. Now, one thing I want to also mention that sometimes you have to be careful when you manage, like hypothesize that this bacteria will be better than the other, only to discover that you're replacing one with one good one with a bad one, or one bad one with another bad one. So now there's also some evolution of understanding how to allow the gut to choose its own bacteria by giving it prebiotics instead of probiotic, which is selection of special population of bacteria.
Let's look at the future then. So what's the Holy Grail? What is it that we are just needing to conquer, and we may conquer Alzheimer's? Or will we conquer Alzheimer's?
Yeah, well, I think the challenge with Alzheimer has been, not finding the one factor that could be the cure for Alzheimer's disease. So amyloid was really the predominant hypothesis that accumulation of amyloid result in a neurotoxic effect and result in the changes in the tau and tangles and so on. So right now we have the very first successful attempt to remove that pathology rather than just treating the symptoms. What I think will happen will be more refinement of first the mechanism of removing amyloid. So we're probably going to have safer way of removing amyloid, detecting it earlier, but also start preventing it. So people that are currently treated or we're approved to treat are the ones that have symptoms. So they have mild cognitive impairment due to Alzheimer's disease changes. Now, that's already 10 years into the illness, because the accumulation of amyloid happens 10 to 15 years, then you start showing the symptoms. So my thinking that, well, the first thing hopefully we'll be able to start give this to people who are not currently symptomatic, but they do have the pathology, so then we can prevent it from happening to start with. But also refine the way we do it to make it safer, more accessible. So instead of having to go to an infusion center and have to stay there for 2-3 hours, having it as injectable at home, sometimes even in pill form. So that could happen. And then try to target other mechanism of the illness. For example, if amyloid is going to accumulate and you can clear amyloid, have you completely gotten rid of the problem, or is there another cascade of events that happen, such as inflammation, neurotoxicity? So we need to also continue to understand the full spectrum of the pathology. But the other thing that you just alluded to earlier is like lifestyle and what is preventable. So if I have high blood pressure, I control it and this and that. So I don't think there'll be one treatment, but what I think may happen that we will have such an advanced analytics, including precision medicine with advanced deep learning, machine learning, to allow us to stratify the risk, to say in this particular individual who may have inherited something from their parents to have amyloid, but they also have high blood pressure, they also have maybe been eating food that's not as good for them, who do not exercise. So we're going to start having probably more precise risk stratification using advanced analytics and give people the tools to modify their individual risk. That's for me will become, like cancer therapy. You no longer just say, I'm going to give this drug to everybody who has this cancer. Now we profile people to say what stage of the illness you have, what factors affect you, do you have these receptors or not, and you can get a precise treatment for your cancer. That's going to be the same, hopefully, for cognitive health, where we're going to address the multiple factors, but in a very systematic and testable, but also reliable way, so that people will be getting the best chance of avoiding these illnesses, or if they detect them early, to stop them as early as possible.
What role will AI play in this?
I think AI is going to be huge in so many different ways. And again, I'm always careful not to be excited about the new, and there are some things that came and we thought they're going to be the answer and then did not turn out to be the answer. But I think we definitely find AI useful in several ways. One, something that we don't see as clinician is that what's happening in the lab, actually looking at the geometry of these molecules and designing smarter targeting of those molecules. So that work is already in the lab. We don't even see it, right? But if we came closer to our own kind of clinical work, well, one is, as I mentioned earlier, stratifying the risk to say, you're a person that have so many different attributes, including your genetics, your life experiences, your risk factors for heart disease and this and that. Can I give you a tool that by extracting information from you, even without necessarily you doing it, and just give me a chance to know your medical history, and I'm going to access your medical history safely and confidentially, get information about how your heart is working, this and that, and then give you back that information to say, in your case, your chance of modifying this risk will be this way, by addressing this and this factor. So that become a very powerful tool on the individual level to say, I have my dashboard. I sign on to my account and I know how I'm doing when it comes to my cholesterol, my blood pressure, my amyloid status, all that stuff that could be integrated. And then of course AI will also help us in the overall larger data sets that we have, like in across society. So instead of the lab people doing their own thing, the individual asking for their certified risk, but also the system need to know what are the trends, what are the things that maybe we're not seeing, that AI would say, there is a trend, like in this particular area, there's higher risk of people developing Alzheimer, so what's going on there? So I think there's a lot of potential. Data is very powerful, and it used to be very difficult for us to make sense of data, so we used to just look at one thing and do statistical analysis and try to control for all the indefinite factors. And the more you add, the more your statistical power weakens. But with AI, you don't need to do that, because the machine will actually identify what's contributing to the factor that you're looking for. And it's going to make it much easier, I think, for us to understand data and continue to update it over time.
We've already seen some AI that will help people hear who never heard before, to see who've never seen before, to move limbs that up until now had been completely detached. Is there anything to be said, because our brain is a big computer, is there anything to be said to wiring into our brain and trying to bypass these plaques and tangles?
Yeah, so I mean, this kind of move us beyond AI. I mean, AI is definitely a component of it, but also in terms of assistive devices and chips and things that could compensate for the functional loss that we have, right? So I think with AI and with advanced information processing, we can afford now putting a device and keep giving it updated information. You've probably heard a lot about self-driving cars, about robotic surgeries, and so those depend a lot on information and having to adjust course based on environmental factors. I think in medicine, some of these assistive devices and implanted devices could benefit from real-time information flow and the ability to adjust the activity based on the information. I'll give you one example. In epilepsy, for example, in seizure disorder, typically there will be a source of the seizure in the brain where nerve cells or collection of neurons are born with a different chemical or wall kind of structure, and those cells are vulnerable to start discharging electricity unnecessarily or in a way that creates a seizure. There is a possibility, obviously, if you have a device that detects those signals as early as possible and very quickly create a little impulse to stop it from happening. I don't think that's far. Like in epilepsy, because those are very defined, like you have the focus of the epilepsy. In memory disorders, the question, could we do what we can do, what we have been able to do for vision, for example, where I cannot make new memories, but I have a microchip that replaces my hippocampus and will allow me to get that information whenever I need it and feed it back to me. So what we really need is advanced chip technology, but advanced analytic and deep learning, so that will continue to be updated and get smarter with time. There's always the ethics of this that has to be addressed in terms of where the person now become not a person. And I think that's why I've always advocated for ethicists and society to weigh in on this in terms of, are we looking to replace ourselves, or are we looking to extend our reach? So if I lose a limb, I use prosthesis, that's not at this point unacceptable. But there was time in the past when they say you can't replace a limb that God gave you or something. Like, so we have to be really aware of what people's framework and understanding. So while we are very excited about all these developments, we also need to be doing it responsibly, because it can get very easily abused, and also the equity of who can afford a device that you can implant. So if I lose my memory and I have a chip that replaces that, I no longer have the forgetfulness and I can function well, but is this accessible to everybody that has that problem, which is actually, we're talking about really large number of people worldwide, like in the millions. Yeah.
Where do you think we'll be, and just wrapping up here, where do you think we'll be in 5 years, 10 years, and maybe 20 years?
Yeah, I mean, 5 years, I think it would be reasonable to expect that the disease-modifying therapies will become like a commonplace. So it's no longer this rare thing you can only access through studies. So in 5 years, it's going to be part of our clinical practice. And we're going to continue to see improvement in that. That's for the kind of medication and biological treatments. I think we're going to see a lot of advance in 5 years as well of the individualized information processing for the person to know their health system, and they'll have a tool that gives them a dashboard. I think that's not that far. I'm hoping that in 10 years, like, we'll be in a state where you'll be able to actually have a self-selected profiling and go to your specialist with a very specific, precise question that is generated by your AI agent in a way. So if I go to my doctor with basically the way I do it today, and I have to ask all these questions, and I'm making inferences and guessing about things. But if I go to my doctor and the profile have already reached my doctor, and the doctor have already identified some of the areas, and they will just inform me that, you know what, based on, here for this problem, and you already gave me the pre-data, and I saw your dashboard, I think what we need to do is to interfere here. And now, I don't know if they're going to do it in person anymore, but probably people will still like to see their doctors. But I like people to see their doctors, not to spend time collecting information that could be already done, but spend time like communicating and being supported by the doctor in a way. So I think in 10 years probably will be in that era where information flow between doctors and their patients will be automatic and collected. I mean, beyond that, I'm not sure, because I think it's moving so fast that I'll definitely make wrong assumptions. I mean, this is what I can see in the immediate and intermediate term.
Give me one last roundup encompassing what hope people should have.
Yeah, I'm very hopeful that we are on the right track when it comes to speaking the right language, when it comes to identifying the illness that could be modified. The concern, of course, will always be, is this going to be equitable and available to everybody? I think that's going to be the big challenge. So I'm still concerned about the possibility that there will be a select group that will access all this technology. But it's possible as well, which is kind of reason for hope, that these technologies are no longer going to be the elite, unique, and rare to access. It's going to be a commonplace. And usually, like any market, the more availability, the more supply, the more actually it's going to become more affordable. So I think the competition is going to be very quick and will allow these to be accessible. So a person with Alzheimer's disease no longer should view this as being the end of the journey for them the minute they hear they have Alzheimer's pathology, because I can tell them that what I'm telling you today is 20 years from now, as opposed to where we used to do before, which is I have to wait for the illness to show up and then tell you 20 years ago amyloid started accumulating. So I think the hope is that people will know that you are actually getting much more ahead of that game. So the amyloid that I see today would have been lingering for 20 years before I see you. Now I'm seeing you the first, and we can stop it from actually causing the illness. So
we've come a long way.
Completely, yeah. Like we're in a stage of a phase in our career, and at least in my career, where I can say with confidence that this illness is no longer a death, sentence. It's really an illness that we can modify and manage and keep people alive, and they may die from other causes like all of us would do. But Alzheimer's should be hopefully a thing of the past in 10 years, where it's no longer going to be the illness that the minute you have the diagnosis, you're basically on a trajectory to decline.
All right, thank you for this, and thank you for what you do.
Thank you so much.